State-level Prescription Drug Affordability Boards, also known as PDABs, are actively growing and advancing across the country. Not only are more states considering or working through PDAB legislation, but a few recent drug-specific advisory board decisions have already been made. What about unintended consequences for HIV-related programs? Although prescription drug expenditures are only a small part of the billions spent annually on healthcare, the price of prescriptions is the low-hanging fruit being targeted by PDABs. However, while PDABs aim to explicitly lower the direct cost of prescription drugs for patients, their path does not achieve that goal. This is especially true since the primary means PDABs lean on to lower costs is the mandatory upper payment limit, otherwise known as UPL. A sweeping, troublesome focus of PDABs is price. Evidence confirms a UPL on drug prices would not lower the costs of drugs or save money for the system, such as health plans or government programs, but it would impede patients living with HIV trying to access their medications. A UPL sets a limit on the reimbursement rates of entities such as state health plans. It does not directly affect what patients pay out of pocket or change what manufacturers charge for drugs. Additionally, if a UPL were set to be lower than the acquisition cost for pharmacies, pharmacies would lose money stocking medications. If a pharmacy can't afford to fill a prescription, patients living with HIV are put at risk due to treatment interruptions or even stopping treatment altogether. Upper payment limits also threaten the 340B drug pricing program. State AIDS drug assistance programs, or ADAPs, heavily depend on savings and revenues from the 340B program, as are nonprofit community HIV clinics. 340B's value is found in the spread between the reimbursement rates and reduced acquisition costs by way of the drug manufacturer 340B rebates. According to NASDAD, for more states, a majority of ADAP clients live at or below 300% of the federal poverty level. Taking dollars out of ADAP by reducing the value of the rebates is a disinvestment from HIV-related funding. Reducing reimbursement rates via UPL mandates will reduce the value realized by 340B rebates. Thus, nonprofit community HIV clinics end up with less money, which means they will have to cut services or serve fewer patients. PDABs are embarking on inadvertently creating a service delivery crisis for patients living with HIV. And will patients' copay amount change? No.